Well, over 100 people. Pretty exciting.
Yeah, it's great. Good audience.
Yeah. For middle of August, gotta love that. So these days, under a pandemic, who even knows what month it is and what that means, right?
Right. The number of emails that I'm getting from, they're like, go back to school, get your back to school supplies. Like,
I loved your tweet about indoor water parks, Emily.
I can believe it. I'm not kidding. Great Wolf Lodge is more $84 for a room. Like,
No.
You know how sick you get at the indoor water park, even in the absence of COVID? I mean, it's like a germ.
Right.
Like,
right. Yeah. No.
Do love a good indoor water park, but
yeah.
not now.
Yeah. Under non-pandemic times, it's fun.
Guys, hi, David. Thank you. We are live now for everybody. So just so you know. Hopefully I only swore like once or twice. Sorry, everybody.
Greetings, I'm Ed Steinfeld, Director of the Watson Institute for International and Public Affairs. Welcome to this special Watson webinar, COVID Today, Is America Really Ready to Reopen? Our special guests for this broadcast are Professors Ashish Jha and Emily Oster. Ashish is the KT Lee Professor of Global Health at the Harvard University T.H. Chan School of Public Health, and he's also Director of the Harvard Global Health Institute. On September 1st, I'm very delighted to say, Ashish will formally join the Brown University faculty as Dean of the Brown School of Public Health. In addition to being a practicing general internist, Ashish has great expertise on healthcare systems and health policy. And as many of you know, he's been writing, commenting, and consulting extensively on the COVID pandemic. Emily Oster is the Royce Family Professor of Teaching Excellence and Professor of Economics here at Brown University. She's a noted expert on health economics and statistical methods and has been writing extensively on the response to the COVID pandemic. Emily is also one of the co-authors of the extremely useful and informative website, COVID Explained. Emily's research focuses in part on why people fail to make what seem to be rational health choices, whether with respect to diet or lifestyle or contagious disease, relevant to today's discussion. Let me just say a word about how today's webinar will work. For about the first 20 minutes or so, I'll ask Emily and Ashish some questions, but then we'd like to open it up to you all in the audience to take your questions. For those of you joining us via Zoom, please write your questions in the Q&A window. And in fact, you could start doing that right now. You can just write your questions in and we'll get to them. And for those of you joining us via YouTube Live, you can also write in your questions, do so in the comments section, and those will get to me. Again, don't wait, please start asking questions now. But Ashish and Emily, let's turn the conversation over to you. And again, thank you so much for being here today. So just to start off generally, where are we right now with the pandemic? I mean, we seem to be in a very different place from where we were in March and April. The pandemic seems much more widespread nationally with red zones and case incidents appearing throughout much of the South and Southwest. We see resurgence in the Midwest and even a slow uptick of incidents in places that seem to have the pandemic really fully contained. So maybe if you could both give us a sense of just where we are right now. Ashish, do you want to begin?
Sure, I'm happy to, and thank you for having me. And excited not just about this webinar, but about joining the Brown faculty. I think it's going to be a lot of fun. So let's talk about where we are with the pandemic. Remember, this is a global pandemic, and the pandemic across much of the world is raging in places like Brazil, India, Russia, large parts of the Middle East, other parts of Latin America. Things are really quite bad. In the United States, I would say we remain kind of the global hotspot. And as a country, we're certainly generating more cases, more deaths than anybody else. Though Brazil often, and many days often has as many deaths as we do. But from within the United States, what I see is much of the Sun Belt was the hotspot. They are starting to level off. but you see a lot of states in the Midwest really picking up in terms of number of cases in the middle of the country. And then the Northeast, as you said, Ed, is starting to creep up as well. But the big picture point is that a pandemic that began with big focus areas in New York City, parts of the West Coast, Detroit, has really become truly national. And a pandemic that initially began in kind of dense urban areas has made its way into suburban areas and has made its way into rural areas. And that has all sorts of interesting implications for the health systems in those places and how we are going to manage it. And maybe the last point as a starting is that we continue to see real divergence in political leadership. You see lots of governors who continue to take the virus very seriously and are trying to do things to kind of keep it under control, and lots of governors who are doing really just the bare minimum and are and not taking the virus seriously and not doing the things that we know can bring the virus under control. And they're going to have very disproportionate effects on those populations.
And Emily, could you give us a sense of where you think we are?
Yeah, so let me just sort of add, I mean, I think I agree obviously with everything that she said. Let me just sort of add two things. So first, the title of this is like, is America ready to reopen? And I think that kind of, that framing is almost a bit like, that isn't, I think, the right frame, because this is, although it is a global pandemic and is affecting all places in the US at the moment, those places are being affected really differently. And part of that's about leadership, and part of it's just about the sort of the way things have evolved. And so the answer to any, are we ready to open X, is going to be different in different places. And I think that that some of the conversation is missing that sort of that piece of the nuance, the idea that like we're not gonna have the same answer to the question in any location. I think the second thing I will say is, in the early part of this pandemic, we kind of went into this place where it was like, either we're totally open or we're totally locked down. And I think there were reasons to totally lock down at the beginning. That seemed right. As we move forward, I do not think there may be cases in which we should move to a fuller lockdown, but I'm not sure we're going to see as much of that. I think the political appetite to do it, even in places that are kind of well functioning, is lower. And I think the economic appetite to do that is more limited. And so I think what we're going to need to see, the kind of leadership I'm hoping we'll see, at least in places I live, is people sort of saying, okay, as things tick up, what are the steps that we need to take to keep that from continuing to happen? And what are the pieces that we need to lock down? And how can we kind of titrate that to keep things under control, while recognizing that, it is probably there. That may keep us from needing to say, okay, nobody leave your house. And so I think we're entering that phase, and I think it remains to be seen whether places can do that phase effectively.
I want to get to the question you just raised, Emily, about what do we need to do, but maybe just to back up, I think some people, maybe even myself, have kind of a lurking suspicion that the resurgence of cases, the spread, it is due to reopening, and it kind of leaves, again, this lurking question of, are we ready? Can we ever be ready? Or is it just, do we have to expect that as we reopen, we're going to see variants of red zone, orange zone, yellow zone?
So let me start by saying, absolutely, the increase in cases is with reopening. To me, like the moment you start having more activity, people get out, the number of cases will go up. The question is, how much? What are the activities? Can you use other tools to stamp it out? If you think about South Korea, which is often heralded, and rightly so, for having done a fabulous job. I mean, they did so well that they had nightclubs open. Now, we had nightclubs open in Phoenix, but that was irresponsible. There were nightclubs open in Seoul, and they at least could have made the case it was not irresponsible because their caseloads were so low. But then they had this terrible outbreak from a nightclub where one person who was infected happened to unfortunately go to 6 nightclubs in one night and infected, hundreds of people. Within 4 days, they had tested tens of thousands of people, identified every single person infected, identified everybody who was a contact of those people, identified everybody who was a contact of the contact, and essentially stamped it out. So the point is, did their reopening of nightclubs cause an outbreak? Absolutely. But they could manage it. And my argument has been sort of twofold. The reason we needed a national lockdown in March is because we didn't have testing capacity. We had no idea where the outbreaks were happening. And second, we understood the mechanisms by which this disease spread so poorly that we also didn't really have a good grip on how to get it under control. Beyond not having a political appetite, which I don't particularly have any expertise on what we have a political appetite to do or not, I don't think it's necessary to have any more lockdowns, because we can use far more nuanced strategy because we have much better data, and we can do things. There may be some places that get bad enough that you need to think about something as close to a lockdown. But in general, I don't think that's what is needed for the country.
Emily, you've written extensively about, particularly for schools, what I think I could say best practice would look like, or at least what some of these mechanisms would look like. Can you describe them?
Yeah, I mean, I think that, the one, so we sort of think about school reopenings, I guess, that sort of the two like response things that I would highlight are, as she said, sort of the ability to test and contact trace, and sort of think about, okay, if there is a case when people talk about schools, there is sometimes this idea that like we should only open schools if nobody at the school will ever have COVID. That's not realistic, and that's not a standard that we should hold. I think not a standard we should hold schools to. As we open schools, there will be people with cases. The question will be, how can we keep those cases from spreading? And a piece of that is going to be, how do we respond to, like, how do we get the sick person out of the school immediately? But a piece of that is going to be, how can we test and contact trace and kind of isolate in a thoughtful way so the case does not spread. So it's not a nightclub, it's, an isolated small number of cases. To do that, we are going to need testing and contact tracing that is effective. And I think for me, we sort of ask, like, what are the many things that keep me up at night about schools. Our total inability to get people test results in a small amount of time is among the high points of the things that keep me up. And I think that's something we sort of said, like, what do we need to invest? What kind of resources do we need to invest to make it possible to, like, not be South Korea, because I don't think that's feasible, but to get closer in that direction? We do need to improve our testing infrastructure. We've needed to improve our testing infrastructure since March. We improved it, and then it was not improved enough, and now it needs to improve more. And I know Ashish is like more like kind of sci-fi about this than I am, and is much more optimistic about like having a very fancy testing. But I think, at a minimum, we need to improve that for schools to be for us to be able to deal with schools effectively.
Ashish, did you want to add anything about testing infrastructure?
Only that I spend like 10 hours a day thinking about testing. And so I feel like sometimes it's hard for me to have perspective on all of it because I'm so in the weeds. I will say this, which is testing, I have believed from the beginning, is key to essentially getting much of our lives and our economy back. We have failed to develop a testing infrastructure. I think when the president, whether jokingly or not, in Oklahoma, in Tulsa rally said, I told my people, slow the testing down, please. I actually think that has been a signal out of the White House to really slow down how much testing we do as a nation. Because I think he actually honestly does believe that testing is leading to more cases. But the bigger problem here is that the testing infrastructure we have is woefully inadequate for our nation. And while I have been pushing very, very hard to ramp up our testing infrastructure, in the last couple of weeks, I have come to basically conclude that we're not going to do it. We're not going to be able to figure out how to get more testing out of the infrastructure we have, and we need to shift gears. While we can continue doing PCR testing, we need totally new modalities. And the good news is that those exist, and now we need to figure out how to ramp up those other modalities. And the other modalities have strengths and weaknesses. But I believe we can get to a point where we can have ubiquitous testing. But whether those show up in 3 months or they show up in 12 months is going to be driven in large part by policy.
I mean, I think one thing to sort of highlight on the testing, which I think that I'm interested in Ashish's what you think about this, is that I think part of what happened early on is we've been using these PCRs and we're thinking about testing as like a diagnostic tool. And sort of like testing is like, when you're sick, you get a test, and therefore it's very important that the test be like really correct because you are feeling sick, and we want to know if you have this. And then we sort of started to move into people saying, well, actually, it's important to do more asymptomatic testing, more screening, to do this stuff. And we talk about that for schools, we talk about that for overall populations, colleges, et cetera. But we kept thinking, okay, the tests have to be these like good tests, that our screening needs to be just as good as our screening tests need to be just as good as this other thing. And I think that, Erin Carroll had a piece that I thought put it really well in the Times the other day, which was just saying, look, for screening, like we don't, if there's like a 15%, 20% false negative rate, that's okay if you're testing everyone, if you're testing everyone every day, or you can use it for surveillance, it's okay. If the false negative rate is actually reasonably high, way higher than we would accept in a diagnostic test. And I think we haven't made that shift. I think we're going to have to if we want to actually like have a better sort of surveillance testing infrastructure.
My question is, what do we do though with the data that these tests are generating? In other words, yes, there are, I guess, many barriers to expanding testing, but once we get those results, do we have the capacity for contact tracing? Even behaviorally, will people admit to whom they've interacted with? How do the next phases work after we ramp up testing to make the whole COVID response system work effectively?
You want me to
Emily,
Ashish, now that's two questions. You can do the whole thing.
Part of it's behavioral though for you, Emily, but Ashish, go ahead and we'll get to the behavior.
Right. So a couple of things. On the testing, Erin Carroll's piece was very good. I had a piece, I think the same day or around then, about the need for what and probably I have to come up with a better marketing term, but the need for cheap, fast, mediocre tests. Like, I think mediocre tests.
That's not a good pitch.
I know. That's why I said I need a better. But here's the thing: the point is not. So here's a bit of a crazy statement. The point is not to identify everybody who's infected. The point is to identify everybody who's infectious, and we don't even have to get everybody, but we need to get a good large chunk of them. And there is a difference between being infected and being infectious. You can be infected, but not have a lot of virus and not be spreading much. There is a window in which infected people are really infectious. And these kind of mediocre tests actually do quite well if you get people in that window. They don't do so well if you're outside that window. And my take is I care less about somebody who's infected but not spreading. I care a lot about somebody who's infected and spreading, right? So we want to be able to do tests that come back quickly. There are tests now, we have the technology where you can get a result back in 30 minutes, and they'll usually get most people who are infectious. And they'll occasionally miss somebody, but if you get enough of them all the time, you'll actually drive the pandemic incredibly, like, to a point where you may not even need to do contact tracing, though I do believe contact tracing in general is a really useful adjuvant to this. And contact tracing, and I will definitely and want to hear from Emily about her views on the behavioral part of this. It has struck me that we've had a lot of kind of simple thinking about contact tracing. Like, first, for a little while, it was like, we'll use apps and apps will solve all of these problems. I'm like, no. And then, and what we have learned—
why not on the apps? What's wrong with them?
Because there's a huge behavioral component. And like, all of a sudden, if you start sending out pings to everybody, hey, you were near somebody within 6 feet of somebody who's positive. Like, if I got that, I don't know what I'm going to do with that outside of be a little annoyed and a little disturbed. So it's got to be much more nuanced than that. Other countries have done a pretty good job on contact tracing. I believe we can. It is hard work. And we don't have to be perfect. You don't have to get everybody. Our entire strategy should not be contact tracing. It should be one of the tools we're using. And even if you get 50% of the contacts, even if you get 30% of the contacts, you'll actually make a big difference. Again, my goal is to get to 70, 80% of contacts. But the point is that even modest amounts of contacts can be a really useful part of a broader strategy for getting the virus under control. We keep looking for silver bullets, and we keep figuring out that every one of these things is not a silver bullet, but we've got like 3 or 4 tools, and you put them all together and the combination is the silver bullet.
Emily, you want to go ahead?
Yeah, so I mean, I think that last point is actually, I think, a really important one, that somehow we have this idea that like, well, no individual thing is sufficient, or people, well, we're going to tell people to wear masks, but not everybody's going to do it. Well, that's okay. If most people wear them, that's actually a lot better than nobody wearing them. So the fact that like not everyone will do this thing is not the same as saying we shouldn't do it. I mean, my view on contact tracing is that, it is it is going to be a useful piece of the pandemic control in certain circumstances where things are already pretty like dialed down, like not rampant. So in a place, in like the sort of current situation in Texas and Florida, or like the situation from 3 weeks ago, I think contact tracing is pretty hard. It's kind of like everybody's contact. Many people are infected. You're not going to get control over that. In places like New York or, Rhode Island, like places with more limited, or in individual schools, as we sort of think about opening them, that's where I think we can do some contact tracing more effectively, because we have a smaller number of people we can isolate, and we can actually like dial into figuring out who their real contacts are. Like the other piece is we have to actually try to limit how many contacts people have. So if you sort of think about the CDC definition of like, people that you're within 6 feet of for more than 15 minutes without a mask or whatever, like that, I think that's what the CDC has said. We got to kind of like make there be fewer of those people. So if everybody's wearing a mask all the time and trying to stay distant from people, then you don't have as many, we could sort of try to limit your contacts, like people who live in your house and people, you have close, like, other people you're sleeping with outside your house. And that could kind of be like your contact set.
Emily, could you say a bit more about other behavioral aspects? So whether it's mask wearing or hand washing or social distancing, what's your sense of how people have reacted, why there's been resistance, and thinking forward, how much resistance is there going to be moving forward to doing these basic things that are all going to be important for containing the pandemic?
I mean, I think that there's like, if you sort of take something, my sense is that mask wearing that's not my sense. It is true that mask wearing has been the most controversial of these. People don't want to say, oh, I don't want to wash my hands, because then like, nobody wants to say, it's like, well, why not? What's the matter with you? And sort of similarly, social distancing, like people don't want to do it, but it also hasn't, like we don't talk that much about it. Mask wearing has become a thing. And I think there's kind of like two pieces of that. There's one is that, similar to, we told everybody to, in the sort of case of HIV where people were supposed to use condoms, actually it's kind of annoying to wear a mask. And, it's kind of uncomfortable. And so there's a piece of it, which is just like, I really want to do this. I would prefer not to be wearing a mask. So I think we're always going to have that piece. And then obviously there's this other piece where this just became like this weird political thing. And I think we know whose fault that is. And it's not yours. And then it sort of like, it was imbued with somehow, when I wear a mask, it becomes, it is a sort of political statement. I think that's going to be simply very hard to, undo. That's gonna be hard to undo.
I want to turn to the Q&A in a moment, but let me just ask one last question. Say 6 months from now, presumably we won't yet have a vaccine, or at least one not widely deployed, but hopefully we'll be in a place where the incidence of COVID is contained and stabilized. Just describe for me what that looks like in terms of our environment, in terms of behavior. So what ideally is our environment going to look like to get to that more stable situation? Ashish, Emily, either one.
You get to pick.
Ashish, go ahead. Paint a picture for me of what best practice is really going to look like for us.
So I tend to be an excessive optimist on what our future looks like, and so there are. I'll paint two pictures, and then I'll tell you why I'm optimistic about the more positive one. The negative picture, which I think is where a large chunk of the public health community is, says 6 months from now is February, and February is not going to be a good month for the United States. And that story says in February, we'll have all been indoors for large chunks of time. The flu season usually peaks in January, February. Our hospitals get full in a good year. And we will have large amounts of COVID, not just in the South, but across the Midwest, across the Northeast. And that we will have a lot of people getting sick and a lot of people dying, and things will be pretty terrible. And we may see rolling lockdowns. We may see states shutting down for extended periods of time. Schools will definitely be closed. Universities will be closed. And that it's going to be a pretty rough December, January, February, March, until a vaccine really starts becoming available and that people start being able to get outside. And that, I think, is in some ways a bit of a consensus view among public health people. And I think that's wrong. And I will at least try to, but it's important to understand that like really smart people think that is the consensus view. And I'll give you my best. I think we're going to have at least one therapy that will make a big difference in terms of mortality. And I think it's coming, and it's monoclonal or potentially polyclonal antibodies. And there are all sorts of questions about will we have enough doses and production and supply chain. I'm going to leave all those aside. Second is I do believe we are going to have ubiquitous testing available. We will be able to do testing for many, many millions of people a day. I think that'll make a big difference, because if you know you're infected, your behavior will change. You will not, hopefully not as many people who know they're infected will go out to a bar. We may have bars and restaurants and many other things closed, but I am more optimistic that we'll be able to open schools in February than I am that we'll be able to open schools in September. And I just think because of the underlying changes in technology, we make the disease less lethal, we make it easier to control, and in large parts of the country, I think things will be better. And then there will be a light at the end of the tunnel, because we'll have probably 2 or 3 vaccines. None of them will be widely available yet, but many of them will be heading towards that, and that'll give people hope. That's my very optimistic view of February, but I don't know.
Emily, what's your sense, say, for
February?
I
mean, that's interesting. I feel like this is a place where I don't have much of a an instinct. I think I would kind of like the picture that Ashish is drawing. But you know, I think I've certainly heard more of the first one, and I think I feel like the sort of where we are in terms of our understanding of the virus and our kind of progress on treatments is like very different than where we were 4 months ago, and therefore it is very difficult to think about where we will be 4 months from now, particularly because it's not my space. So I don't know. I guess we'll see.
Hopefully we'll be in a better place. Let's go to some questions from the audience. Ford Shaper asks, through the COVID Explained website and Dr. Jha's blog, it's clear that both Dr. Jha and Dr. Oster strongly value good data, which seems to be lacking in regards to the coronavirus, particularly in regards to how the virus has affected people of color. I was wondering what methods you both have used to overcome these gaps, and how the way we collect data could be improved to improve our understanding of the coronavirus and how it has affected different communities. And I think particularly people of color. Emily?
I mean, I think that, you know, I think that in general, our data collection has fallen down a lot. I think our evidence now on cases is somewhat better. And actually there are, you know, many places have pushed to try to say more about the demographics of those cases. I know Rhode Island has, to try to, you know, sort of differentiate out the differential impacts on communities of color from the rest of, to sort of separately isolate that information. But you know, this hasn't been a place where data has been widely available or collected, and I think it's one of the, you know, many failures of the kind of broad response to this.
The only thing I would add, Ed, is how ad hoc our processes have been. That some states are doing a fabulous job collecting data, other states are doing a terrible job. If you want to ask the question, how many tests were performed in the United States yesterday, you have to go to COVID tracking. And COVID tracking is run by a bunch of journalists, and they are fabulous. They're great. But a group of journalists like pulling together, and by the way, that's what the coronavirus task force of the White House uses. They use COVID tracking. So the White House doesn't have better data. They're using the same data that Emily and I and you have access to. That's pulled together by a group of journalists run by a bunch of guys at the Atlantic magazine. Like, this is nuts for a country of our size capacity to outsource all of our data collection efforts. What that has meant is that there have been progressive, thoughtful departments of health that have done a great job on trying to collect data on race and ethnicity, and others who just have not. And CDC has gotten into the game and tried to collect data on some of this stuff late. CDC has been, its data collection efforts have generally been abysmal for about a month and a half. They were taking the weekends off on data updates because we're in the middle of a pandemic, and why not take weekends?
People need a weekend.
People need weekends, but the CDC should not get weekends. Like, somebody at the CDC should still work on a Saturday. So there's just been this like ridiculous level of incompetence on data. There was a National Academy of Medicine event or like gathering last week. We were talking about kind of what do we need to be doing? And I was like, first, like, we just have to start acting like a functioning nation that has basic data elements. And when we also have to get some amount of clarity on what are the data elements that we actually care about and want to measure. Even this morning, the president in an interview with Axios was, bringing up all sorts of data stuff. Like, no, those aren't the things. Nobody cares about the metrics. So the key data elements and the key metrics, we've got to get some level of agreement, and then we can fight about how to improve and what the right policies are. But we have not been able to get on the same page on the same basic book of facts.
We have a question from Penelope Skalnick, and she asks, I'm wondering about the safety of sending kids back to school, in my case, pre-K age. Given the many, many overwhelming factors to consider, are there a few key points that can help us make this decision, assuming we have the option to send our kids in person? Emily?
Yeah, and so I've been thinking a lot about this decision from the and so there's a bunch of pieces of this, but let's just sort of think about from the kind of parent standpoint. I think the sort of big things I would have in mind are, what does a community transmission look like in your area? And so, if there's a huge ongoing outbreak in the area you live in, you probably should not send your kid back to school, even if you can, at least in the short run. I think that there should be a lot of differentiation across ages. And so sort of thinking about, reminding ourselves at least that younger kids, elementary school age kids, younger are less, they get less sick. They seem to transmit less than older kids. I think we should be focused on having those kids in the classroom first. It is also the case that those kids probably benefit the most from face-to-face learning. And the other thing for families to think about is just, what is your alternative plan? How good or bad is that plan? And so I think sometimes people have been structuring this decision, just saying, like, should I send them back to school? And I've really been trying to encourage people to say, or what? Like, what is your other choice? Is it that you stay home? Is it that, your spouse stays home? Is it that there's a grandparent? That sort of somehow thinking about what the alternative is may help make this decision, because I think otherwise people are kind of like, it is challenging to sort of work through the details without knowing what you're trading off with.
Great. Let's turn to a question from Georgia Gallant. What do you think about pool testing? Do you see it being implemented? Ashish and Emily, what's your sense of pool testing?
I like it. I'm a fan. I'd vote for it. No, it's good. It's an effective tool. People worry a little bit about loss of sensitivity that once you pool, but I think, and Emily made this point, and I have as well, I think, I'm both a physician and a public health person, so I'm going to beat up on one part of my identity over the other. I think we've been thinking too much like physicians and not enough like public health people. And physicians care deeply about, and Emily made this point, about getting the diagnosis right. Public health people care deeply about getting it right for the population. And we have to do both, but this pool testing, yeah, you lose a little sensitivity. But the idea is if there's a really infectious person in that cohort, it'll still show up. And so I think we have not deployed this effectively enough. It's an incredibly effective way of expanding our capacity, especially if the underlying incidence is low. And so I'm a fan. We should do more of it.
Emily?
Yeah, I mean, I agree. I think that it is part of like a sort of large set of things I think we should be more of, which are on their own, maybe not like the piece, but like wastewater testing, I'm like a little more skeptical about, but I think in this space of kind of like, I know you like fine, wastewater, test the poop. And, but I think there's just like a lot of these things we could be doing, particularly if they are, relatively cost effective.
We have a question from Dick Barker. He asks, much is being bet on effective vaccines. There's a significant percentage of the country that's adamantly anti-vax. Do you expect that to limit success? Emily, do you want to talk about some of the behavioral aspects of?
Yeah, so I've worked on the sort of anti-vax piece of childhood vaccinations. Clearly, a lot of people don't like vaccines. They don't like new vaccines. They think that they're anxious. This and the other thing. And if the first vaccine is the Moderna, if that's the thing that we get first, that is a kind of vaccine we've never actually used before. I'm not sure how that maybe end up being kind of opaque to people, but there's gonna be, oh, we've never tried this before, we don't know, like it might turn you into Spider-Man. Like, so I mean, we're definitely gonna get some pieces, some pieces of that. But I think sort of there are two things that a vaccine will buy us. One, some people will get the vaccine, and that will be good. And so, we will, like, many people will be eager to get this vaccine. I think in part, some of the resistance to existing vaccines is that nobody knows anybody who has the measles. So people think, why would I get my kid the measles vaccine? Nobody I know has the measles. That piece of it is like people are thinking about COVID. They know that it is a risk. It's a thing that people get. So I think that will help us. And I think the other thing is, once we have a vaccine and you could get it, then it will be much more difficult for people to, there will be a pressure to reopen, and to do things, even if, even for, like, so things like teachers, right? So many teachers are resistant to going back to school. Some of that is well placed. Some of that is probably overstated. Once there is a vaccine, if you say, I'm not going to get the vaccine, but I also don't want to go back, that is going to be treated very, very differently. And I think that will mean there will be more pressure for kind of opening, and that will sort of drive pressure for vaccinations.
Great. Ashish?
I completely agree with all of that. And when I've looked at the data, about half people say they get it, about 30% say they're not sure, and 20% say, no way in heck am I getting a vaccine. And the way I look at it is that 30% is probably quite persuadable, and we don't have to get everybody to get a vaccine. And at the end of the day, like, I'm going to decide based on the data, right? So if you ask me, are you going to get the vaccine? The answer is I'm really pro-vaccine, and I will get it if I'm convinced that the data is there. And that means that the FDA has done its job and that we have enough data on safety and efficacy. And so I think a majority will get it. I also think the disease dynamics will totally change even once you vaccinated another 20 or 30% of the population. The spread of the virus will dramatically get lower. And what I worry about is there will be communities where the rates of both infection and immunization from vaccines will be very, very low. And then they will become places where the virus spreads much more effectively. Because it's one thing to think about national immunization and immunity rates, but of course, America is a country with lots of mini communities, and you can imagine there'll be communities where there will be much more challenges. And so I worry about that. But as a nation, I think we'll be in a very different spot a year from now.
In recent days, the media has reported maybe pressures from the White House to accelerate the development of vaccines. And, the implication was that maybe safety standards are being reduced. How do you both feel about that, both with respect to the accuracy of those reports, but also how is the public going to absorb that kind of information, that questions the safety of the vaccines because of the rapidity with which they're being developed?
Let me start here by saying I am not super worried about it. And I'll tell you why I'm not super worried about it. So first of all, like the number of people who have sort of said, October surprise, we'll have a vaccine, it will get shortcut, the FDA will feel pressure. There's a lot being done to inoculate the FDA against pressure. And I think of it this way. If, like, a week before the election, the FDA shortcuts a lot of data and says we have a vaccine, like, are Americans all of a sudden who are planning on not voting for the president going to switch? Like, I don't know. And again, they're political scientists who understand this much better than I do, but October surprise works if there's a surprise, but I don't see this as a surprise. Second is that the pressure to get it right is going to be so intense that I don't really see the ability to have a vaccine with enough safety data. We might have efficacy data, but I don't know that we'll have safety data by then. And if we do, and if it's done well, and we've got 30,000, 40,000 volunteers, and 3-4 months in, no one's showing much in the way of severe complications, like, I think we'll all evaluate that and make a decision. But I am largely not worried. I don't see corners being cut. I see things being sped up in a way that are mostly reasonable, but there's a cost to not speeding up, right? There's a cost to taking 5 years to build a vaccine. So I think this is one of the few instances where the federal government has really gotten this right. I think it's been largely led by Tony Fauci, which is part of the reasons they've gotten it right. And a little plug, we're doing a little event with Tony Fauci on Friday. So please join us for that.
That's a webinar with Brown President Christina Paxson.
Exactly. Exactly. So that'll be fun. Friday, 1 o'clock, I think. And but the point is that I'm pretty confident on the vaccine. I'm pretty bullish on the vaccine, and I expect that most people will get a vaccine sometime early in 2021.
Early when?
Early 2021. And on this also, I am beyond consensus. Consensus among public health people is it's much later in 2021 or maybe 2022. And I think people are just being way too pessimistic. I don't think we're gonna have one vaccine. I think we're gonna have 4 vaccines by sometime in early to mid 2021. And I don't think an American vaccine will be there first. By the way, there are no American vaccines. These are all international collaborations. But the first vaccines will come out of China. And then we'll have some from both Europe and the United States by the end of the year.
If there's time, we can come back to that. I have a number of questions, but a number of people, Barbara Oberketter, Lee Costin, have asked a question about case numbers. So I'll just read Lee Costin's question. Where there is little testing, how are case numbers determined? Emily, I mean, you're both statistical experts. Do you want to comment on that, Emily?
Yeah, I mean, the sort of tracking of cases and prevalence is really like problematic and complicated. In part because if you sort of think about like what would you really like, you would like a kind of like a random sample of the population to be tested every day, and ideally with something cheap, and then you would sort of have some sense of like the prevalence. The idea that the number of cases is somehow like a relevant piece of information is, I mean, of course it is a piece of the information, but what you care about is the prevalence, in which you could get from different kinds of, random or universal testing, none of which we have. And so the result is that, the case numbers are moving around with the amount of testing. All right, so if you test more people, you get more they're moving around with the prevalence and with the amount of testing. And so, what that means is if you want to have a lot of cases, then you can do a lot of testing. And if you, much more problematically, if your goal is to have few cases, you could just not do that much testing, and then you would get lower, right? Am I wrong? Ashish, is that not?
No, I have a slightly different take, but please finish your thought. I don't mean to interrupt.
Tell me what you think about it. We can have a dialogue.
Yeah, no, so it's, I think the number of cases matters a lot, but it's got to be interpreted in the context of the number of tests and the percent positive, right?
Yeah.
And so this is one of the reasons why people have often said, well, are we in so much better shape because we have so many more cases than we did in April when New York was in really bad shape, and yet our death numbers are so much better. New York's percent positive on tests was around 40-50%, which is awful. It basically meant that New York was probably missing 95% of cases when it was just because of the testing capacity limits. So I track every day, every evening, I look at for every state in the country, number of cases, which I think really does matter, but has to be interpreted in the context of the number of tests and the percent positive. And when the percent positive rises, my brain does a mental calculation of the number of cases is way being underestimated, and I have to do some sort of a correction, and there's no good formula for correction. So it is a bit of a complicated issue, but number of cases as prima facie matters. And the best example of this is New York is doing an extraordinary number of tests, and they have fewer cases than Oklahoma. Because their underlying prevalence is low. So I'm not disagreeing with anything.
No. I mean, I guess what I would say is I think that these two pieces, there's the percent positive and there's the number of cases, and they are individually largely not that informative. Together, they are quite informative, exactly. But you need to sort of put them together because you can, in some sense, I feel I could manipulate either of them very easily. If you told me I need you to target like a 1% test positivity rate, I just go out and test a bunch of people I know don't have it.
Exactly.
Right. Similarly, if you told me I need you to target, fewer than, 50 cases a day, I guess I could just test 49 people and I would be guaranteed. So in some sense, like those two pieces they have to go together.
Exactly.
And I think that's kind of the key.
Great. We can come back to some of the data. In fact, there's an additional question about data. Harry Chalfin asks, since the USA's daily new cases are higher now than they were in the spring, why are the daily new deaths still not as high?
I think there's two reasons for that. One is that we haven't seen the deaths catch up. I think the deaths are probably still catching up to the cases, just to some extent. So for a long time, the deaths were very low. And so they're clearly like pretty lagged. I think there's another piece, which is, there's two, I guess the other piece is that the case fatality rate of the people we're testing is lower. And I think that's partly that we're doing more tests for people whose fatality rate is low, like, people in their 20s. And partly that there has been some improvement in fatality rates, even for older people. Some of the treatments we've gotten better treatment. So I think for those, am I missing any
Nope,
pieces?
those are the three. Those are the three.
Great. Ashish, did you want to add anything?
Emily got them all.
All right, super. Thanks.
But why bother?
Super. Robert Purcell asked a question, quite a specific one to reopening of campuses across the country. What testing turnaround period is regarded as needed for the reopening of campuses generally?
Professor Oster, you want to take that, or do you want me to?
Why don't you start with that?
All right. So there's no like set standard, right, that says you have to do it by X. My take is if it's more than 48 hours, certainly if it's more than 72 hours, it's totally useless. Under 48 hours should absolutely be a goal, and my very strong preference is that we should be at 24 hours. And it's just an issue of like, how much are you willing to miss? And the longer you wait, you're just going to miss more ability for people to transmit. So somewhere in the 24 to 48 hours, I can live with. And what I would really like is 15 minutes. Thank you very much. And I think that's possible, not with the current tests that are available, but again, the kind of tests that I think will be available by November, we can get there. So 24 hours is really my goal and hope, but 48 hours is probably okay. We can live with that. Beyond that, it starts becoming less and less useful.
Yeah, I agree with that.
Emily, do you sense that's true for public schools, even thinking beyond campuses?
Yeah, I mean, I think that, the sort of public school districts that I've seen talking about testing, and these are mostly pretty richer places, talking about testing, have sort of talked about trying to use rapid testing more. I think a lot of campuses have talked about versions of surveillance testing and or uniform, like doing a lot of testing. I think most schools are not talking about that kind of testing. So they're really talking about, what are they doing when there's a sick kid? How do they test that kid? How do they test the other kids in the class? And there, I think that there's been some effort to sort of push towards things that would come back really quickly, because, if you wait 10 days and you tell everybody you have to be home until you get, until we get the results of this kid's test, and it's like, it takes 10 days to get it. That's not really, that's not good. It's not feasible.
Emily, you mentioned your answer was in reference to wealthier school districts. What about poorer school districts? Are you seeing any examples of creative solutions there for testing and general infrastructure for resumption, or even globally? Is there an answer that is more equitable than just the rich neighborhoods are going to do better?
I mean, look, this has laid bare the fact that our school districts are unbelievably unequal, a fact which we already knew. And now we know even more in an even more extreme way than we knew before. There are wealthy school districts that are talking about, oh, every kid's going to get a Chromebook and, like a personal Sophia antigen machine so they can, there are, poor school districts where it's like, well, we don't have any school nurses in our schools. Like, we get a school nurse comes for 45 minutes every 3 weeks. And, and they have, it's like, well, our teachers have to buy their own colored pencils. So I don't really know how we're going to install a new ventilation system to make it safe to open. So, I think these problems have already been there. They have been there for decades, and they are sort of in your face in a way that they were not before. Without more resources, there are many places where it simply will not be safe to open. Will they open in a way that is unsafe? Maybe some of them. Is it fair to ask kids and teachers to go back to that? Absolutely not.
Ashish, go ahead, please.
So we've been working with a bipartisan group of both Republican senators and Democratic House members to try to initially get a lot of money for schools in the previous stimulus bill. But we think we're going to be able to get a chunk of money in the current stimulus bill. Again, I wish we had passed it 4 weeks ago. I really don't have any influence on the congressional calendar, but in it is the idea of having testing money for every school district in America. And it's a large chunk of money. Whether it's even a good idea, whether schools will be able to implement it, whether they'll be able to get somebody to do it is a different question. But I have been obviously a big advocate of getting testing in schools and trying to figure out how. There's no way 80% of school districts in America could possibly afford to do testing. I'm not sure that this bill will solve it. I'm not even sure that the final bill will include it. But we have been trying to get resources for both improving things like ventilation, but also testing for schools. It's just, I wish we had been able to get this passed a month ago when it would have made a much more of a difference than getting it passed in mid-August.
Great, thank you. Let's turn to a question from Arameti, who's watching on YouTube Live. And Arameti asks, I'm quite concerned about the politics and commercial competition working against the public health best practices of implementing a vaccination campaign in the US and globally. Could you comment on that? And I understand the question to be, once a vaccine is available, how is a global production system going to intersect with geopolitical competition or commercial competition? How is that likely going to play out? Ashish, Emily, either one.
Ashish, you thought more about this than I have.
So this is a really important topic, and there are two elements of this that I want to take on. One is, how do we get equitable distribution in the United States? And then the second is, how do we get equitable distribution around the globe? And there's been a lot of work being done on equitable distribution around the globe. There are companies, so one of the major producers of vaccines for the world is India, and there are a couple of major Indian pharmaceutical companies that are already have started ramping up production of the Oxford AstraZeneca vaccine, for instance. So my hope and expectation is that we're going to see a lot of production outside of the OECD countries where that will allow for distribution. I am not super worried about getting vaccines to people in China. I am not super worried about getting vaccines to people in India and South Asia. But once you get into Latin America and once you get into Sub-Saharan Africa, it's just much, much harder, because India has often been the producer of these things and China has been, but they're going to focus on their own countries first, right? There's going to be very strong pressure in India to make sure everybody in India has access to vaccines before those vaccines end up elsewhere. So we do have real problems there. WHO has been a major and very helpful coordinating organization on trying to create a global supply for vaccines and making sure everybody gets it. In the United States, there are very specific issues, and a lot of us have been pushing the White House to share with us plans for distribution and making sure that there are no financial barriers for individuals, that it is given at the point of care for free to people, and that it is distributed widely, and that there is a particular plan for making sure that underserved communities have access and are not left behind. And we have not seen the level of detailed planning from the White House that I was hoping for, and I'm going to ask Dr. Fauci about this on Friday to see how he has thought about it.
Emily, did you want to add anything?
Anything to add to that? That seemed good to me.
Okay, great. There's a question from Erica Sevitson, and she asks, what will it take for people to be able to take part in the performing arts again? I'm especially thinking about live music, chorus, bands, et cetera, which means lots of potential for spread of respiratory droplets.
Widespread vaccination. I mean, I think unfortunately, there are things that we hopefully can do sooner than that, but live singing in groups, this is not going to happen until we have a vaccine.
And Emily, there's a question, a number of people have asked a question relating reopening of public schools and the practices needed for that to practices needed for safe voting. What's your thought about the relationship between opening of schools and voting? Is there a relationship? Are lessons transferable?
I mean, I think that, they share the feature that I think both are important for civic functioning. I think the sort of two important differences are that, actually it is possible to vote by mail. Whereas, and voting by mail, although not as good as voting in person, is probably substantially closer than trying to teach a 5-year-old to read by mail or Zoom. So I think that sort of the alternatives that we have for voting are in some ways much better. And it is also, I think, easier to imagine how people could safely vote in person, although again, I think I think it is easier to imagine the logistics of safely voting in person in some ways than the logistics of of school. So, I see the parallel because they're both these sort of civic activities, but I think the practical details are pretty different.
Great. We're reaching the end of our hour, so maybe time for one or two more questions. There's a question from Meg Guerin Calvert. Apologies if I'm mispronouncing any names, who's from the Center for Healthcare Economics and Policy. What roles do you see for multi-sector collaboratives in local communities to expand capacity and overcome some of the challenges you've discussed, involving better testing, tracing, masks to improve response? If there are successes there, how can that experience be shared nationally? So are there some local multi-sector best practices that maybe we can draw some lessons from? Emily?
I don't know, Ashish, I totally understand.
Or even globally, have there been any local actions at the subnational level or state level, county, town, that really look promising?
I guess to the extent that I think I get the underlying principle behind the question, it has struck me that in this pandemic, one of the things that I think we've learned is that, sort of straight up public health advice from scientists doesn't magically lead to broad scale behavioral change among everybody in the world. Shockingly, another way of saying shockingly, not everybody listens to everything I have to say. What has been really clear is that places that have done better have really engaged local civic leaders to amplify and validate that. And so, like any kind of movement that requires large scale behavioral change by people, it has always, in my mind, has worked best when it's been multi-sectoral and not just come from scientists or public health people or from economists or any one group. And that certainly feels like a model that we have to think about for vaccines. It's a model we have to think about when we try to tackle problems with people getting tested. So that's kind of a generic answer. I don't know if I have more specific than that.
Great. And maybe we'll end with this question. This is a question from Kristen Sills, and it's to you, Emily. Kristen asks, can Dr. Oster talk about the socioeconomic impacts of keeping kids home from school? Women especially are bearing the burden and dropping out of the workforce to care for and homeschool kids. Can our economy withstand this kind of economic strain on top of everything else?
Yeah, I mean, I think there's sort of two big pieces of that. So one is just, what are the impacts on low-income kids, students of color, what is happening to learning? And I think we know from the spring that there were huge drops in learning outcomes for all kids, but especially for students who are in schools. So we saw those much more significantly in schools where there was a larger share of the students were in lower income populations. So I think that there's a sort of pretty clear inequality that has been created by the absence of in-person schooling. As we think about going to the fall, that will sort of continue to be true. We've already seen very extreme forms of this kind of inequality in places where schools have gone totally virtual, like in California, where then we have the micro school, I saw something on Twitter today where somebody was advertising we need the best possible teacher for a pot of 7 kids. If you find us a teacher, we'll give you a $2,000 Uber Eats card. That's not for the teacher, that's for the person who finds them the teacher, right? So we're now in a space where rich people are getting all kinds of, rich people are having their own fancy micro schools and poor people are not experiencing that. I think this inequality is just really extreme. And then on top of that, in families in which, you have somebody who's going to have to stay home with the kids, that is more likely to be a woman. And we're going to see, women dropping out of the labor force, women taking a break from the labor force. We know that those breaks have long-term career consequences. I see this in the women that I talk to and the women that I work with, that, we're home all day with our kids. And the fact is that mom is usually the default. Is usually the default parent, and so it doesn't, you're trying to do your job, you're trying to do your Zoom, and your kids are coming in to be I need help with this, I need help with this, I need help with this, and eventually people are forget it, I can't do both of these things. And so I think we're going to see those consequences for a very long time.
Thank you. Well, we've reached the end of the hour, but let me thank the audience for tuning in and for providing such great questions. Let me especially thank both Emily Oster and Ashish Jha. Ashish, we're so happy you're joining us here at Brown and the faculty. I'm so honored to be colleagues with both you, Emily, and you, Ashish. And thank you both for all the work you're doing to address the pandemic on behalf of all of us. Thanks so much.
Thank you, Ed, and thanks,
Thank
Ashish. It's great to talk to you.
Be well, everybody.